Let's go.
Okay. Okay. We can start.
Okay.
All right. Okay. So hi. Hi, this is Your Healthier Life. And today is World Prematurity Day. I'm Dr. Swallow, and we have with us a wonderful guest. We have Dr. Mwenya Chatulika, and she is a neonatology fellow at the UTH. I'll actually start by just sharing something personal that actually Mwenya and I go way back. Yeah, so we actually were in high school together and we graduated together. One thing that I remember, a memory that I'll share, Mwenya, was, do you remember how sometimes when it would be really hot in the afternoon, we would one after the other leave class, and then we'd take these long walks. We go wash our face like far, far away, and then go back to class.
You actual malingera. Touring the entire school during the afternoon period.
Yes, I'm really excited to have you on the channel. You can introduce yourself if I haven't done a good job already.
I think you've done a good job. Dr. Mwenya Chatulika, current neonatology fellow at Women and Newborn UTH. I work with fantastic people. I did my internship first at Cancer Diseases, then UTH, and I'm now in ICU. Okay.
All right, great. Okay, so we'll just jump right into the discussion. So today is World Prematurity Day, and we'll be discussing prematurity. Our conversation, the outline, we'll just start with, first of all, defining what prematurity is. We'll go on to discuss some of the risk factors. We'll touch a little bit on the complications that are associated with prematurity. When I'll then go on to tell us about the hospital management, what it includes, and the discussion will end with some advice for mothers on discharge. So that's about right, yeah? So Mwenya, what exactly is prematurity? Hello, are we, Mwenya? Okay, we have some technical difficulties, so we'll just wait slightly for Mwenya to join us again. All right, you're back. Can you hear me?
I can hear you. Sorry, tech issues.
Yeah, okay.
Mhm. So,
Yeah, so we can start with what
prematurity.
is prematurity. Sorry. Hello, Mwenya. Hello, Mwenya. Okay, I can't hear you. Your mic is off. I still can't get you. No, your mic is still off.
Can you hear me now?
Yes, I can get you now.
Okay, perfect.
Yes. All right. Okay.
Sorry about that. Had to change devices.
All right. Some technical difficulties, but we are back.
We are definitely back. So,
all right, great.
Prematurity, right?
Mm-hmm.
Prematurity is essentially all babies that are born before the expected time. In Zambia, we count in worldwide, it's 40 weeks. Okay,
Mm-hmm.
That's we count in weeks and not months. You understand it later on. So we expect our babies to be born by 40 weeks. All babies that are born before 37 weeks, after 28 weeks completed gestation, that's premature babies. So that period from 28 weeks to 37 weeks. 37 weeks is essentially 9 months plus 1 week. All right, regardless of the weight. Okay, so why are we talking about prematurity today? November 17th is celebrated as World Prematurity Day. This year's theme is zero separation. What that simply means is that we as healthcare workers want to limit the separation between babies born too soon and their parents, and their mothers, their fathers. We want them to bond as quickly as possible. We want to involve the parents in more family-centered care, essentially. That is what zero separation is all about.
Okay, and so in regards to the theme, what does the actual setup right now on the ground look like in terms of your management of neonates in the NICU?
Okay, so I'll discuss that later on in detailed proper management. But essentially what that means is immediately a baby comes to our NICU. If the baby comes with the mother, we speak to the mother from the very get-go. If not, we try and call the relatives so that we can speak to them. We allow for visitation, mothers and fathers, during a set period of time, mothers to come every 2 hours for feeding as well as visiting. They're allowed to ask questions at any point. If we note any changes in conditions in the neonates, we always are very quick to call the parents. We want to get them involved in the care. If we need drugs that we don't have, we tell the relatives so that they can provide these things. We're very family-centered. Even our bereavement, our counseling, death counseling is really family-centered.
Okay, that's wonderful.
Yeah.
And now going to what exactly some of the risk factors, what leads to a premature labor?
Okay.
Or preterm labor. Yeah.
Unfortunately,
Unfortunately, 50% of premature cases, you can't identify an actual cause or a risk factor. But for the other risk factors, I like to divide them in, it can be either the fetus, the baby itself, it can be the mother, it can be environmental, things like that, right? For the fetus, it's if there are multiple gestations, twins, triplets, that would predispose you to having a preterm delivery. Essentially, what you need to understand is the uterus works like a balloon, eh? Beyond a certain point, it will stretch beyond, if it can't stretch beyond a certain point. If it stretches at its max point, that triggers your start of labor. So the more your contents, you have more triplets, you have more fetus, you have 2, 3, you're more likely to have a preterm delivery. On the mother's side, you look at age is very important. Young mothers, less than 18 years old, mothers that are older than 35 are more at risk of having a preterm. Infection is really common, especially syphilis, UTIs, those would predispose you to having a preterm neonate. Actually, we advise for early screening of UTI for any infection. Maternal conditions like diabetes and BP, either pregnancy-induced BP or long-lasting chronic BP, will predispose you to having a preterm infant. Additionally, smoking, unfortunately, in our setting, lower socioeconomic status will predispose you to having a premature baby. Conditions like malnutrition, anemia. Our setting, we are more at risk of having anemia because a lot of us are actually undernourished. We are essentially malnourished. Additionally, if you're going to have a baby 2019, another pregnancy 2020, another pregnancy 2021, you're stressing out your body, you're more likely to be undernourished, you're more likely to be anemic, and you're more likely to have a preterm baby. Also on the mother's side, if you look at the uterus, any distortions in the uterine shape will predispose you to having a preterm baby. Either a bicornate uterus, differences in the shape, or fibroid uterus as well. Fibroids, again, really common in our setting. Additionally, problems with the placenta. If the placenta is overlying the cervix, if you have an abruptio, essentially the placenta detaches from the uterine wall, that bleeding may trigger you into having a preterm delivery. Additionally, things like the environment now. Pregnancy, quite right, it affects the mother, it affects how the mother is going to be, but pregnancy is a dynamic state, it involves everybody involved, right? So stress from outside, any trauma from outside will predispose you to having a preterm delivery. Okay.
I think from all the different possible risk factors that you mentioned, first I'd like to highlight the thing that you said was that for 50% of preterm labor, right, preterm deliveries, there actually are no causes, right? But then again, the other 50% are instances in which the cause is known. So that means that 50% of the time for a mother, she can do something, isn't it? And there's so many different conditions that you've mentioned. For example, if she has pre-existing medical conditions, you mentioned diabetes, hypertension, meaning the key there is ensuring that her blood pressures are maintained and controlled, that her sugars are controlled. She's on top of her game in that regard. And then you mentioned something about infection. So that's another important advice that we would give, to say that, okay, antenatal care is important. Ensure that you are going to your antenatal visits and that you are being tested, you're being screened for any infections, and they are treated before delivery and treated on time. Other conditions you mentioned in regards to fibroids, I know I'm not how it's done in your hospital, but I know in our hospital, those are mothers who we are constantly monitoring through their deliveries, through their pregnancy, and just trying to delay any possible preterm labor as much as possible. So I like the fact that you said, you know what, 50% fine, there's no cause, but with the 50%, there's actually something that can be done. So for a lot of mothers, they should pay attention to that, that there's actually something that they can do. And also the other important thing that you mentioned, sorry, was malnutrition. That's something else that also should be highlighted, that it's important that women, I think women should prepare themselves for pregnancy, yeah? When they're considering it and so forth, and giving themselves time to recover.
That's actually how I look at it. Pregnancy needs to stop being an impulse, but more of a planned discussion, a planned decision that people make. Because prior to being pregnant, you should be ready for the costs of pregnancy. You should be ready to deal with any sort of pregnancy outcomes. You should be ready to accommodate this baby that's coming in. And you should be put essentially your body into a state of well-being, a state of health that allows you to have a safe delivery, a safe pregnancy.
Yeah, okay, that's great. The next thing that we'd like to touch on is then, okay, fine. So we're speaking about women who have gone into preterm labor and they do find themselves having premature infants. So at this point, this infant is then taken to a special place that is called the Nicu, right? And so from there, what does the management look like?
All right, so before I even dive into the management, I want to tell you about why preterms even end up in our facilities in the first place. Okay, preterms are essentially, what you need to understand about preterm infants is these are immature neonates. These are immature babies. So when you look at them from top to bottom, everything is immature, all right? So usually what happens in your first trimester, your first few months of pregnancy, that's organ growth, the formation of organs. Your last trimester is now, your baby is gaining weight. Your baby is collecting all the essential minerals, all the essential vitamins, all the essential nutrients from the mother. And thirdly, the other thing that is going on is there's maturation of these organs that formed earlier. So if your baby is born preterm, you're cutting off that very critical period. You are cutting off the neonates' chance to gain weight. You're cutting off their chance to mature their organs. You're cutting off their chance to collect essential minerals and essential vitamins from the mother, right? So your baby is going to be predisposed or affected by certain things, essentially. From the top down, from the brain is also going to be very immature in that normally your brain is able to control how blood is passing through, right? How blood moves around your brain. A preterm infant is more at risk for developing this difficulty controlling that blood flow. So they essentially to put it in very layman's languages, it's what is essentially happening is that you have these mini bleeds in the capillaries. As your blood flows from the heart, the small vessels that go around, you have those mini bleeds. Okay. Too low. It's too low. Sorry, adjustments on camera.
Fine.
So yeah, essentially you have these mini bleeds in the brain. Okay, that earlier on can affect your baby. Later on will end up affecting your baby with cerebral palsy, things like that. As you go further down in the eyes, remember your neonate has not yet matured. Okay, so even again, the vessels that are supposed to be forming in the eyes at about 8 months, they don't have time to do that. So you remove your baby too quickly, your baby is affected by this outside environment, can cause these minute damages in the eye, as well as the retina of the eye. Okay. Next, it's a whole thing. You move down, think of it, every single part is affected. Every single part of the body is immature. As you move down, your baby is going to have breathing difficulties. Okay. One, the respiratory muscles, the muscles that control breathing in a neonate, in a preterm neonate, are going to be weaker. Your baby will have these episodes where they tend to forget to breathe. I like to put it this way. The baby is so dependent, is still thinking, oh, I'm in my mother's tummy, my mom's going to breathe for me. Your baby tends to forget how to breathe and has these periods where they sort of shut down. Additionally, as we have the lungs, right? You have your trachea, your bronchi, your lungs. Your lungs are surrounded by this fluid known as surfactant that essentially helps that in and out motion, right? By 32 weeks, you expect this surfactant to be forming. If your baby is born earlier than that formation, your baby is going to have essentially stiff lungs. I have a brilliant boss. She explains it with a balloon. I don't have a balloon. I'll try and get one before the question part so that you understand it better. Essentially, your baby is working too hard to do this normal in-out motion because of that lack of fluid, right? So your baby is going to have breathing difficulties. Next, your GIT system. These are preterm infants. Everything is immature. So essentially, you're going to have an immature suck and swallow reflex. Your baby is not able to suck. The milk will go in, if you feed via breast, you put the baby on the breast, milk will enter the mouth, but the baby will be unable to suck. The milk can just be sitting there. Your baby is more at risk of choking. Your baby also, because the baby is not sucking well, is not getting enough milk. Your baby can, these have low sugar episodes, can become hypoglycemic. And then this is a very important part. Your preterm neonates, again, the bowel, the stomach, the intestines are very immature, right? So these are not ready to take food the same way you and I are, the same way that a term neonate will be able to take feed. People have tried, we now have preterm-based formula, Prenan, but it is not a good enough substitute for breast milk. What preterm neonates need is breast milk, breast milk, breast milk. We need mothers to start expressing early because you want to essentially line that gut to prepare that gut for more food. And that only way that proper preparation can happen is if you have breast milk. I'll talk about this a bit further. Again, as well, you see you and I are protected from infection because our skin is nice and thick, our immune cells are working. You don't get that in a preterm neonate. Again, everything is immature. That skin, the barrier of the skin is very thin in a preterm infant, as well as the cells, the normal T, B cells, our white blood cells are not there in a preterm. So they are more at risk of developing infection. Okay, next part as well, the liver. Remember, everything is immature. That's the best way to understand it. So the ordinary work that the liver does, it can't do as much. So your baby is more at risk of developing jaundice, that thing at, oh, mana, yellow. This is made worse in a preterm infant. Additionally, with the heart as well, what happens in utero is that when the baby's in the mother's stomach, the mom is doing everything for them. The mom is providing blood with oxygen, is getting away that dirty blood, is doing everything for the baby, right? So what happens in the fetus in utero, is that the heart has essentially got these little passages to bypass the normal function. Occasionally what happens is there's a kambo, simple English, simple Yanja. There's a kambo in the heart. This ideally should close after birth to a few weeks. With preterm infants, this closure delays, and these babies are more at risk of developing heart failure. Okay. These are, again, infection, hypothermia as well. Remember, these are small premature babies. They can't control their temperatures well. They have poor skin, so they are rapidly losing heat. So these are the complications that we deal with a preterm infant. This is when your question, Kabelele, comes in, Dr. Spallo, sorry, of how do we manage these guys, right?
Yeah.
So yes, I like to look at management as two ways. You manage the environment in which they're in, as well as the medical management. For the environment, our NICU is a very warm place. Throughout the year, October, it's hot outside. NICU is hot.
The worst place to be in October.
It's lovely. It's not bad. You just hydrate. But yeah.
Oh, for us. Yeah.
So yeah, it's warm in the NICU. Remember that your baby's at risk of hypothermia, so you need to keep the place warm. All right. Ideally, we like to use incubators. If you follow Your Health, Your Life page, they've been showing these pictures of incubators throughout this month. That is essentially the little house for your neonates to sleep in. It's humid as well as being warm. Remember, when you put a mbawla, you don't just put a mbawla or a heater. You always put a bit of water by the side to ensure that it's still going to be humid heat and not dry heat. Neonates also need that. Next, we try to reduce sound because remember, it's very annoying to hear constant beeps and noise in your ear, same way as the neonates. And these are very sensitive. Remember, even the ear as well is not as mature as it should be. So any high alterations or changes in sound will affect your neonate and may even later cause hearing problems later on. So we want to minimize on sound. We like to institute a day and night schedule. Essentially, you have lights on at a certain part of the time, you switch them off in the night. It's very nice to have a sleep-wake cycle. Even yourself, if you were in darkness completely, you would get a bit cranky, or if it was bright light continuously, you'd be upset. Same way with the neonates. Additionally, part of the environment is kangaroo care. I'm not going to say kangaroo mother care because it's also kangaroo father care. I'll discuss that a bit later in detail. Additionally, the other thing that we do is we like to nest our neonates. Essentially, we provide a barrier of beddings around the neonate. The neonate has the ability to push against this barrier, is moving against this barrier whilst being protected by this barrier. It increases the neuromotor growth, neuromotor development. So that's the environment. Environment plays a really important role in the management of preterms. Okay, next to the medical. Medical aspect is essentially, we need to manage all these complications that I listed. Right? Hypothermia, temperature changes, fluctuations up and down. We manage by having a warm environment constantly, or we nurse the neonate in an incubator. The breathing difficulties that a neonate has, we put this baby on oxygen. We have essentially 3 different gradings of oxygen. We can just put the nasal prong oxygen, which is usually a single tube that is coming from the baby of oxygen. We can put CPAP. Essentially, these are these thick tubes that we put in the baby's nose to provide some sort of continuous pressure to open up the lungs. All right. Next, if your baby is not doing too well on these above 2 measures, and we now need to, in order to do our work for this baby, in order to save this baby, we may need to put the baby on a machine that breathes for the baby. We intubate and we ventilate this baby. Additionally, other medication that babies that will need, remember I mentioned the lungs are a bit too stiff because they don't have that fluid around them. We are able to give that surfactant. We like to give it within the first 12 hours of life. So it's very important if you're having a preterm neonate, if you're about to go into labor, you know that this baby is going to be preterm. If you are able to, 1, be delivered at a large scale facility, in our setting UTH, somewhere that has a neonatal unit. If you're able to, you can buy surfactant, please. It's very important. That will help. And there are other medications that we do give through the IV lines to assist the baby's breathing, right? Next, our feeding, because remember the baby has this poor suck and swallow, is not able to properly suck the same way you and I do. We need to feed this baby. Less than 32 weeks, ideally, we feed them via a tube, either a nasogastric tube or an orogastric tube. Essentially a tube from the nose all the way directly to the stomach, or a tube directly from the mouth all the way to the stomach. And that's how we feed our babies. With neonates less than 2,500 grams, we want to feed them every 2 hours. Even at home, this is the feeding schedule that you follow, because we want to prevent all these little periods of the baby going hungry. So we ideally like to do continuous feeding. Okay. Other part of the management, remember that these neonates with their very thin skin, they are very prone to developing infection. We do put a cannula, that IV access, to provide IV antibiotics. Additionally, part of our environment, unfortunately, is we like to limit visitors, okay? We want to keep our babies in the most sterile type of environment, so we limit visitors. We don't like too many people coming in, okay?
Okay, well, that was a great answer. I really enjoyed, first of all, hearing you break down in the beginning all of the implications of the immature infant. Yeah, to say that, okay, fine, this patient, the reason that they're essentially coming to the ICU is because all of these systems are affected, and all of these systems cannot be managed at home, right? They can't be managed by the parents at home. And so in the hospital is where, with example, their respiratory system, they'll require that assistance. So there is where the nasal prongs will be done, or the CPAP and so forth. And then with the feeds also, and NGT, one of the things that I, while I was in the NICU for a very short time, while I was there, one thing that always just intimidated the mothers was all of the tubes that were exiting the infants, and that really made them feel uncomfortable. So I'm glad that you were able to explain exactly why all tubes are necessary and why they are, and so that was great.
Actually, can I just talk a bit more on
sure.
the time in the NICU? We are very understanding. Like, ideally, we understand that when you're pregnant, you want to carry your baby 9 months, you want to take your baby home, you want to have your naming ceremony, you want to show the baby to the relatives. We understand that's the very normal response. Having a preterm baby, or a baby that requires admission into the NICU, is very stressful. Either on the part of you've carried your baby 9 months, something happened in labor, or the baby was born with something, or something is wrong and your baby is rushed to the NICU. It's a very stressful process. It's very scary, and it's very intimidating. We understand that. On the side of a preterm, your baby is born early. Your baby looks fine. Like, it looks small, but your baby looks fine, and you don't understand what is happening. We understand that. So in this whole zero separation, family-centered care, ask questions at every point, be involved in the management of your baby, read a bit when the process of making pamphlets for our NICU so that parents can be aware. Both mother and father come and be involved in the care of your baby. Ask all the questions, demand answers. We don't chase people. We will answer your questions. We will guide you. We'll show you what's what. So it's very stressful, and understandably, but come willing to learn and understand that these things are being done for the benefit of your baby. Ultimately, it may not look that way. It may look like these people keep touching my baby. They want to draw bloods. Why is there a tube from the nose? Why is there this baby on oxygen? Why have you intubated?
Why are we poking your baby with these needles?
Yes. We need to do these tests. Neonates, again, require several tests, especially if there's infection. These require several tests. If this baby is ill and is not responding to our normal treatment, we need to test this baby. We need to feed this baby with a tube. All of this is done for the ultimate benefit of the baby. But if you're not sure, ask. It's really no one will get annoyed with you for asking.
And another thing that I think is really important with such a day as World Prematurity Day, considering that prematurity is one of the leading causes worldwide of admission, it's important that every of childbearing age really understands what that is. If you're not affected, you may then have a family member who is, and you're in a completely different space if you completely understand what the implications of preterm labor and prematurity are. I think in terms of comfort that you would be able to offer a family member or your wife or a friend, very different when you actually know what this is. So this day is wonderful that we're able to have such a conversation and talk about something that is almost hidden sometimes.
That's very, very important, because you occasionally, we have, in my discussion of kangaroo care, so kangaroo mother care, follows the guideline of kangaroos, essentially. They keep their neonates in a pouch, keep them very close to the chest. That is essentially it. Your mother or the father is seated comfortably. I don't know if you can see me essentially, but your neonate is being held in the middle of the parent's breast, like this. Neonate is in a frog leg position. The head is tilted to one side. And you tie the baby, you can tie with a chitenge around. The mother is able to do her tasks around the house. She's able to move. But this connection, this skin to skin care is very essential. Remember, as I said, your baby is like, oh, I'm still in the womb, my mother's breathing for me. As the mother's breathing, that is able to regulate the baby's breathing. The mother's heart rate as well is translating. The baby is getting, oh, this is what I'm supposed to be doing. The baby's stomach, the baby's intestines is lying above on the mother. So even then, that bowel activity, remember your intestines move like this, peristalsis. The baby's also getting, oh, that's what I'm supposed to be doing. So KMC, kangaroo mother care, kangaroo father care, is important for nutrition. It's important for regulating temperature. It's important for preventing these periods where the baby has that stop and start in breathing. It stimulates a conducive, a stable environment for weight gain. Kangaroo mother care, kangaroo father care is so very important. And not just the mother and father can do it, older siblings as well. So long as you trust them to hold the baby, they can also do this kangaroo care. And it's all benefiting your preterm infant.
Okay, so then how many hours in a day would you advise a family to kangaroo
so there are
mother
two different
care?
types. You can have intermittent kangaroo mother care or continuous kangaroo mother care. Intermittent means that after you feed the baby, you can put the baby on your chest 30, 40 minutes, you put the baby down. Continuous, remember what I said is, you put your baby, you can wrap your chitenge around you, you can put another blanket, a layer, and the baby's here, you are able to do anything else. You are able to wash plates, your baby is here on the chest, you're able to entertain visitors, you're able to do anything. Your baby is just here on the chest. So it can be continuous throughout the day. There's no time limit really.
Okay, that's wonderful. And another thing that I actually learned recently just to bring up COVID, during COVID, something that was more or less emphasized on the ward was encouraged was how the patient should be in prone position, because it's like the perfusion to the lungs was essentially better. So when I thought about kangaroo mother care, I realized essentially the baby is in prone as well. And so the perfusion to the lungs is improved. And so that breathing by being in that position is also done in a better way, to be better.
Yeah. Sorry, you had cut, but I think you were saying that putting the baby in kangaroo is essentially putting the baby in prone position, right?
Yeah. So essentially enhancing perfusion to the lungs and all of that breathing.
You see the benefits of kangaroo care. So one more point. 2 people made this baby, yes? So the care of this baby is dependent on the mother, is dependent on the father. Fathers must be involved at every step of the way. Relatives at home, your grandmothers, your ambuyas, listen, what is needed? It's a very stressful environment for the parents involved. The mother essentially is coming every 2 hours to feed this baby. Provide support. Be it you take food to the mother, you ask her how she's doing. These questions of muchokaliti, wazamchita discharge liti, it stresses the mother. Your best part is support, or also to ask what is happening, what's going on with the condition. Yeah, sorry, I cut you off. You can continue.
Okay. Yeah, we should have essentially talked about this earlier, but then we didn't touch on the complications, the short-term complications of prematurity. But then again, you have more or less talked about it in terms of all the implications into every system and how it's affected. But then what would happen long-term?
Long-term.
With the baby, when the baby is discharged, are they completely fine? What should parents know about that?
So, okay, let me do the long-term complications, then I'll tell you how we end up discharging our babies. So Again, remember I said the brain has these vessels. The brain should be able to control how blood is passing through those vessels. In a preterm baby, that control isn't as good or isn't there. So the baby is more at risk of, let's say, mini strokes or mini bleeds in the brain. So this baby can end up having developmental delays. This baby can end up having cerebral palsy. Again, as well, the eyes, by 32 weeks, that's 8 months, that's when you now start having vessel formation in the eyes. If your baby is born too early, your baby is more at a risk of visual impairment, problems with my glasses, but I was at preterm. Visual impairment, can even be blind at certain point. These babies as well, their eardrum is not as mature. These babies can have hearing disabilities. Additionally, this is a baby that may have been on oxygen for a long duration of time. This baby is also at risk for infection, so will have these repeated chest infections, can end up having something known as chronic lung disease, or that these are part of the complications. Additionally, this preterm infant, because of that poor suck swallow, they may end up having poor growth over a long period of time, or difficulties growing, can be malnourished at a certain point. These are all the long-term complications that we really worry about.
And you said you touch a bit on the discharge criteria. So at
Yes.
which point is this premature infant fit to go home?
Okay, so ideally, every center should have their discharge criteria in place, but for us, what we look at is sustained weight gain, at least 20 to 30 grams in a day, and your baby should have, we have a target weight of 1.4 kg, 1,400 grams. Next, this discharge weight can fluctuate between different hospitals or different centers. Our center uses 1.4 kg. You must have, but they must be sustained weight gain. Every day your baby must gain 30 grams, 30 grams, 30 grams. Next, you also need to have, the mom needs to have adequate milk production, 20 to 30 mils of milk production in a day. She must be able to, or this mother must be able to afford formula and has committed to giving formula. But ideally, remember, this is a preterm infant, we want breast milk. So 20 to 30 mils of milk in a day should be able to feed that baby, the baby's requirements. Next, we must be done with our medical issues. Remember those breathing difficulties? We can't discharge a baby that's still dependent on oxygen. We can't discharge a baby that still requires IV antibiotics. We want this baby to no longer have those breathing difficulties, is having sustained respirations. The breathing is not changing in room air. This is a baby that doesn't require oxygen. This is a baby that we will discharge. Two, again, they're very important. We also look at social support. If we discharge this baby, will this mother be able to take care of this baby? Does she have any support, either with a partner or with her parents or with family? Does she have anybody there in case she fails and this baby needs somebody, right? The other thing that we need to do in order to discharge you is that we want this mother to be comfortable. Remember, a preterm neonate, prematurity not only affects the baby, it affects the mom, all right? We need this mom comfortable with caring for a preterm neonate. We need her comfortable with holding this baby, with latching and breastfeeding this baby, and also providing minerals and vitamins to this baby. Remember I said in the last trimester, your baby is essentially collecting all the essential minerals, all the essential vitamins from the mother. We need to continue that process. We need to continue supplementing those minerals, supplementing those vitamins until roughly 6 months of age. So the mother must be ready for all of this. She must be able to give. She must be producing adequate milk. She must have some social support. The baby must be feeding well, either by cup or via breast. The baby must be gaining weight well, at least 30 grams in a day. And additionally, we must have dealt with all of our medical problems. Then we are very happy discharging this baby.
Okay. From everything that you've explained, it just makes me understand that for a neonatology fellow or neonatologist, anyone in that NICU setting, to discharge a patient means that they are confident that that mother and that baby essentially are ready to go, and that they can, you know, go into the environment. Because I can imagine being in the NICU setting and having all of that support, you can become very comfortable and start to rely on the doctor telling you everything is okay. And then that hesitance to now you go. You know what I mean? I think that can be a little bit
that fear is there, and it's very, very understandable. You know, you have some times where we've stayed. Additionally, the premature babies have a very long hospital stay. So that's why support is important. You can become dependent on the doctors, on the nurses around you, on the healthcare workers, providing you that additional comfort, that support. So fear is very natural. Fear is it's a very natural phenomenon. But what we try and do is we essentially are empowering you to be able to take care of your newborn. And we also tell you the danger signs to watch out for. Before we discharge you, we tell you the follow-up, the necessary places to go, as well as the danger signs that you need to worry about. Danger signs include any fever or any fluctuations in temperature, difficulties feeding, this baby not feeding, this baby not being as active as it was, any yellowness that is noticed in the skin or any changes in color, any seizures, either can be excessive crying, this high pitch, this scream, this wail that the baby's having, or even just the baby freezing up. Okay. These are all, we give you all these danger signs or these parameters to watch out for in your preterm.
And then how often, sorry, are you, you can go on.
On the follow-up is very, very important. So remember how I started off by saying in neonates, we don't count months, we count weeks. So there is this thing that we use, corrected gestational age. So essentially, you may say that, okay, my baby was born at 32 weeks of life, right? 32 is essentially 8 months. Ideally, we want to the target is 40 weeks, meaning that your baby was 8 weeks short of being term, 8 weeks short of where the baby was supposed to be born. My baby's born today, 17th November, 32 weeks. December, January, February, March. March, you'd be like, oh, my baby's turned 4 months. Doctor, my baby isn't cooing or isn't making those sounds. Ooh, my baby isn't rolling its head. My baby's not doing this. I'll tell you, oh, mommy, you're saying your baby is 4 months old, but this baby born at 32 weeks is 8 weeks short of where we're supposed to be. So 8 weeks, 4 months minus that 8 weeks, your baby is actually 2 months and not 4 months. So these are very important days that you, as a preterm mother, need to know. The date your baby was born and the expected day your baby was supposed to be born. Essentially, they get 2 birthdays. But the age that we follow in medicine until roughly at about 2 years of life is the corrected gestational age. Using that subtraction of time from when your baby was supposed to be born and when your baby was actually born. So that's very important. These babies, you may think that they're not growing as they should. They may just have these delays, but you think they're having a delay, but they're actually behaving appropriate for their corrected gestational age, for their corrected age. That's very important. Two, other follow-ups.
So it means, sorry. So it means then they can't necessarily call it a delayed milestone, isn't it?
Yeah.
Because then it's there. Okay, fine. You can go on.
What we do when preterms, we have, if there were any other medical issues in our preterms, from discharge, we see them at 2 weeks. We see them again at 6 weeks. We can see them later at 3 months. Ideally, our final discharge weight from D block is 2.5 kg. Because remember, 40 weeks, 2,500 grams. That's 2.5 kg. That's when your baby's supposed to be at. So that's when we discharge you and say, okay, mommy, this is now your baby. You can take care of.
Mwenya, Dr. Chatulika, are you there? Dr. Chatulika. Okay, we're having some technical difficulties, which should be corrected shortly.
I think politely, we need to discuss who is trying to bewitch my internet connection, because this is ridiculous, quite frankly.
Welcome back.
I'm so sorry.
Welcome back.
I've had to again change devices because I don't know.
Yeah, okay, welcome back. I'm glad to have you. Where were we?
So yes, discharge, follow-up. Follow-up is very important. Remember, these babies are at risk of visual impairment, later on blindness. So we like to book them with the eye doctor so that they're seen. Additionally, these babies were at risk of these high sounds, fluctuations in sound with a very immature ear. We want to also get them to do hearing assessment. Next, if there are any neurological delays, we do book them with the neurologist so that they are seen.
All right, I just saw a question from our YouTube platform from Chisala Chivale. And her question is basically in line with what you're talking about. Are there any long-term effects on the brain due to premature birth? If so, what are they? Like, what does that look like?
Cerebral palsy. They can also have hydrocephalus. Remember those babies with a very big head?
Slow down. So when you say cerebral palsy, what does that mean? What does that
Oh,
mean? What does that look like?
sorry.
Yeah.
So, cerebral palsy, essentially you have delays in your developmental milestones. You have by 1 year, your baby is unable to sit without support. Your baby is just making these noises. Your baby can't follow things. Ideally, your baby should start being able to track objects. Your baby's not doing that. Depending on where in the brain was affected, you may find this baby will have seizures, post-bleeding, remember? Because the premature brain is unable to control the flow at which blood is moving, those little bleedings may lead to blockages in how the ordinary, trying to sound very simple, how the ordinary fluid moves. And so you end up with hydrocephalus. This baby's head can become big, can have water, essentially water in the brain. Yeah. So those are neurological delays that you really worry about, especially cerebral palsy.
Those are the burden of conditions like cerebral palsy and hydrocephalus on families. Honestly, I don't think it's discussed enough, really, when you think about it. Yeah, so those are actually very serious complications, and families should understand that they're long-term, that those essentially lifelong issues, and they'll be in and out of the hospital constantly. So we need more awareness of cerebral palsy and hydrocephalus, actually.
World Autism Day is it last month?
Oh, yeah?
You should, I think so. There are very, very good pediatric neurologists available.
All right. Okay, great. But, so then something that I would like to ask in regards to cerebral palsy then, will that patient, that child, will they be completely aware of their surroundings? Will their parents be able to speak to this child? Will they be able to grow up normally, irrespective of all of those motor defects? I think that's something important we can touch on.
I am not a neurologist, so I will not give you the fine details. But with cerebral palsy, it depends on what type. Remember, there are different types of cerebral palsy. It affects your motor as well as your higher function. So one, depending on what type of cerebral palsy that this patient ends up developing, those that are strictly motor, there is some range of communication that happens. Countries like Japan, New Zealand have very good cerebral palsy centers that do a lot of rehabilitation. You do get people with typical classic motor cerebral palsy that are able to function to some extent. So it really all depends on the type of cerebral palsy that this baby ends up having. What you need to know about cerebral palsy, it's a lot of money involved because it's constant rehabilitation. You need to do special chairs for this patient. You need to do constant physiotherapy. Because their muscles are constantly essentially in a spasm, you need to have muscle relaxants. Again, the body is made up of muscles. So even as you're swallowing, those muscles are constricting. Your patient will have difficulty swallowing. We need a nutritionist to come through. We need a speech therapist. Language is not just what you see, what you say, and what you can hear. Language is broad and defined. Ideally, we should be moving to a place in that patients with cerebral palsy, autism, or neuro disorders are allowed to communicate in a way that best suits them, either with music or non-verbal communication, essentially, is very, very important and what needs to be probably worked on in circles. I've gone a lot. Okay.
Yeah, okay. So I think you've answered that question really well. And then more or less somewhat of a follow-up question would be, I'm just seeing it here. It says, when these long-term effects are noticed, can the baby be taken back to the Nicu? I think that's a good question.
I didn't get you. What did you say?
Can you hear me?
No, I didn't get you.
When these when these long-term effects, so the complications essentially, when the long-term complications are noticed, can the baby be taken back to the NICU? I think that's a really good question. Yeah.
Okay, it is very, very good. So even when we discharge the baby, by discharging you, we are not chasing you. We are just telling you that, okay, you're now ready. You come back as and when necessary. If the mother notices any problem, she can bring the baby back immediately. Even we discharge you today, if there's any issue tomorrow, you can come back. If you do notice a problem, these long-term complications, you can bring back to our clinic, but we will direct you to the right person. We usually, because we follow up so extensively, by 3 months, we find we may still be seeing this baby if the baby had other special conditions. Usually by then we have already linked you to the necessary problem. Remember, babies may have that little mbo in the heart, the little hole. We already at this point have involved cardiologists at A block. We link them to cardiac clinic. If the baby needs neuro, we link to neuro clinic at A block. We're very good with linking our patients to the next line of care.
Okay, and I think another important thing, really, I'm not sure how the NICU is run at your facility, but then at our facility, considering a neonate is only 28 days old, after which they no longer qualify. A patient can be readmitted into the NICU at St. Francis. How does it work at the UTH?
I think I say we might be too accepting. We will take, we take a lot. We do have an admission criteria, but like if the baby comes and the baby needs NICU support, we will take. Ideally, beyond 30 days, you are no longer a neonate, and we should have transitioned you to A block children's
hospital. 30
hospital.
days actually.
Yeah, but let's say you were born at. We have babies born 800 grams. After 1 month, this baby is still like 1.1, has not reached our discharge weight. We're still with the baby. We don't chase you just because that 30-day mark has reached. We will keep you until you are ready to be discharged. We accept everybody.
Okay, that's not how it works. Yeah. Yeah, I guess here it's pretty strict, the tight ship. Okay.
I don't know if you want the person in charge of the NICU to be hearing that.
Yeah, no, I take it back.
You take it back. Yeah, we didn't hear that. We didn't hear that.
Yeah, okay. And then I think we'll conclude with, first we'll just questions, but before we do that, I want your last words really to be about the advice. You've touched on it somewhat, but then what advice on a personal level would you give to mothers on discharge as Dr. Chatulika? I mean, I know what the textbook says, I know those things, but then what normally do you just tell these mothers as they are going home?
Feed your baby. Feed the baby every 2 hours. I prefer do cup, because we calculate how much feed the baby needs. Do cup, put the baby on the breast, do KMC. Bring the baby back if you notice any issues. That's really my thingy. But my closing remarks, things I want to say that I feel are very, very important, is that 1, plan your pregnancy, get screened, do all the necessary pre-pregnancy screening, start antenatal care early. Don't wait for 6 months and then you want to start antenatal care early. Get tested throughout antenatal care, because if you develop BP or diabetes during pregnancy, get treated, be consistent to your medication, everything to ensure that this baby is not affected. Once you have this baby, and by chance this baby ends up coming to our NICU, ask questions, be involved in the care, both mother, both father,
Mhm.
be involved in the care, ask all the questions, and express early. These premature infants need breast milk. Ideally, very soon, we will be talking about a breast milk bank. Same as a blood bank, we have donors
Mhm.
tested for everything for breast milk so that we can provide these very critical babies with breast milk in cases where their mothers are unable to, the mothers have demised or things like that. So
Wow. Okay.
express early,
This is the
express
first
early.
time that I'm hearing about
I have
a
hope
breast milk
in
bank.
the people in charge of NICU that these things will
Wow.
happen
Okay.
very soon. Express breast milk is very, very important for these
Mhm.
preterm infants. So I think that's where I can end.
Yeah, okay, wonderful. Thank you so much. I'm looking at our YouTube page to see whether we have any additional questions. Should I say, fortunately, it seems everything was understood. If not, I'm sure our viewers and subscribers, you are free to ask your questions and they will be addressed online. So just feel free to do that. Mwenya, thank you so much, Dr. Chatulika. I should stop saying Mwenya, right? I should stop saying that.
Yeah.
But then, yeah, but Dr. Chatulika, I'm so grateful that you agreed to do this, that you made the time to join us on Your Health, Your Life. This has been a glorious conversation, honestly, and I'm surely hopeful and confident that there's something that has been picked by each person that shared and joined in with us. So thank you so much again for making the time to join us on Your Health, Your Life. And we are confident that we will see you again in another video and discuss something else that is touching to your heart. Yeah, we can do that anytime that you're available.
All right.
Yeah. All right. Thank you very much.
Thank you,
All right. Bye-bye.